Welcome to Going Antiviral, the podcast for the IAS-USA, a professional continuing medical education organization focused on HIV and other viral diseases. I'm Dr. Michael Saag, professor of medicine and infectious diseases at the University of Alabama at Birmingham and volunteer member of the IAS-USA Board of Directors. Welcome to the Going Antiviral podcast. Today, January 16th, 2024, we are speaking with Dr. Susan Buchbinder. Dr. Buchbinder is professor of medicine, epidemiology, and biostatistics at the University of California, San Francisco. She is director of the Bridge HIV Project, a research group whose mission over the last 4 decades is to discover effective HIV prevention strategies in the Bay Area and through international communities. Her research focuses on risk factors for HIV acquisition and interventions to prevent HIV infection. Dr. Buchbinder, welcome to the show.
Thanks so much, Dr. Saag.
So let's start with just kind of a quick history of the epidemic of HIV, how it got started, what the numbers have done over the years, but especially in the last 5 years.
So the very first reports of strange cancers and opportunistic infections happening in gay men occurred June 5th, 1981 in an MMWR. And it was then fairly quickly recognized that there was an epidemic happening. Initially, it was noted in gay men, and then it was noted in hemophiliacs and in people who inject drugs. There was an outbreak in Haiti, so Haitians were included in that category. It was initially called GRID for gay-related immune deficiency, and it wasn't clear what was actually causing the infection. I think it was about 1983 that the antibody test became available, that they were able to identify HIV as the cause of AIDS. And it wasn't really clear in those early years what was happening and if everyone who was HIV infected or HIV antibody positive would ultimately go on to develop AIDS. And we did in those early years discover that there was a group of what at the time we called long-term non-progressors that more recently have been called elite controllers, that were people who were living with HIV for long periods of time and were doing quite well despite the absence of treatment. Treatment came along in the late 1980s. 1988, I think, was when AZT became available, but it was monotherapy and was not very effective for very long periods of time for individuals. And it really was 1996 when the combination antiretroviral treatment was first really found to be effective with protease inhibitors and really changed the entire face of the epidemic in reducing new, disease progression and deaths.
So that means that as treatment came along and death rates were higher in the 80s and people were no longer, the prevalence was smaller, right? Because there were new cases, but people were dying. Once effective therapy came along, the actual prevalence rose pretty dramatically through 2000 to 2020 and actually to today. And so what's the current rough number of people infected in the United States and maybe around the world?
Yeah, so it's estimated that there are about 1.2 million people living with HIV in the United States, and over 700,000 people have died of HIV-related associated causes. Globally, there are 1.2 million new infections each year and 39 million people living with HIV. So quite large numbers of people. This really is a huge pandemic, and it's estimated that there have been over 40 million deaths in people living with HIV globally. So really one of the substantive pandemics of our time.
The means of transmission, I think, are known to everybody. They are through sexual activity, and it could be any type of sexual activity, heterosexual or homosexual activity. It's through sharing of intravenous needles, mother-to-child transmission, but also through blood transfusions, which we don't see anymore. So when we're thinking about prevention, interventions that engage in those activities would prevent theoretically all transmission. And at the beginning, we used condoms and safer sex. So, how successful were we just with that intervention?
Well, I would say that the biggest intervention really were communities coming together to educate each other about the pandemic, and then safer sex practices were put into place, and that actually did really reduce new infections early on. But a colleague of mine came out to San Francisco for an HIV vaccine forum once, and somebody said, "I don't understand why we need an HIV vaccine. People should just use condoms." And she said, if behavior change were easy, I'd be thin. And so I think many people can relate to that. And what we know is that it's really hard to sustain behavior change, safer sex practices, and condom use over time. So fortunately, we do have now very highly effective biomedical prevention interventions that prevent new infections.
Right. And I think the evidence that we were successful, let's say in the 90s, from just the simple interventions of communities coming together, is that the syphilis rates dropped. And then over the last 2 decades, they've come back up again, which means that people aren't paying much attention to condom use or communities coming together to protect one another from transmission.
Yes, I would say that's true. What's exciting is that we also have new interventions to prevent bacterial sexually transmitted infections as well. And so our hope is that those will also roll out.
Right. So you were mentioning besides behavioral interventions, there are some other biotechnologies, treatment as prevention, that type of thing. Maybe you can walk us through a couple of those approaches, especially the ones that you're using in San Francisco today.
Sure. Well, I think that treatment as prevention is a really critical piece. And that was something that was recognized that if people were reliably sustained on antiretrovirals with viral suppression, that they could not transmit to their sexual partners. And that came after many years and many studies that really indicated that people who were virally suppressed were not transmitting to their sexual partners. So that's great. It's something called U equals U, or undetectable equals untransmittable. And so that's important both for the individual themselves to stay healthy, to have their virus suppressed, but also in prevention, in preventing transmission, onward transmission of infection. It's also really important in mother-to-child transmission because it prevents perinatal transmission of the virus. So that's a really key cornerstone of HIV prevention, is treating people who are living with HIV. And that, of course, all starts with having people get tested. It's estimated that only about a third of people in the United States have ever had an HIV test. And it's recommended that everyone get tested. And testing is the gateway to both prevention and treatment if somebody's living with HIV. So we really need to, promote HIV testing as the first step in the prevention pathway.
So one of the things we did to that end was we started testing in the emergency department everyone who came in the door, because we found that people who were ultimately diagnosed with HIV would be in the ER 3 or 4 times before we would discover they had an HIV infection. What are you guys doing in San Francisco, either along that lines or other ways that you're increasing testing?
Yeah, we saw that once we removed, it used to be that people had to sign separate informed consent and go through a long informed consent process in order just to get an HIV test. And that clearly was a barrier to people getting tested. So once that was removed and we really scaled up community kinds of testing, we do a lot of outreach. We do testing in emergency rooms. We do testing in people who are hospitalized. That really because we're not very good at anticipating who it is that's going to actually be living with HIV, both because we're not very good at necessarily taking sexual and substance use histories, but also because sometimes people themselves don't have really high risk behaviors, particularly for women. It's almost 1 in 5 new infections in the United States are in women, and oftentimes they have a single partner. And so it may be difficult to anticipate which which people are going to be living with HIV. And it's estimated about 13% of people living with HIV are unaware of their HIV infection, but that accounts for 38% of new infections. So if we can get people tested and aware that they're infected, we can get them into treatment. That's better for their health and better for prevention.
So studies way back when looked at individuals, providers, and their ability to estimate relative risk of a patient in front of them, and they were terrible, right? They were no good. They couldn't estimate this at all. So what you're saying is exactly right. We should have everyone be tested at least once. I don't care who they are. And what I used to say is anyone who's sexually active or even thought about being sexually active should be tested over time. Another modality, just to wrap up the prevention approaches, is PrEP. And I know that you guys are using that a lot. Can you tell us a little bit about what um, uh, PrEP is and how you use it?
Yeah, so just like protease inhibitors really revolutionized the way that we did treatment, PrEP has completely revolutionized the way we do prevention. So PrEP is either a daily pill or a pill around the time of sex or a bimonthly injection, and it's pre-exposure prophylaxis. So you do that on a regular basis, and it prevents probably more than 99% if it's used as directed, as of new HIV infections. So it's very highly effective. And as I said, it's really revolutionized the way that we do HIV prevention. And there are many different options depending on both your sexual practices and your gender as to what tools you might use. But as there are actually 4 different tools, 2 different pills that could be used, 1 pill that can be used around the time of sex, and as I said, also this long-acting injectable treatment that lasts 2 months that has been found to be even more effective than pills because sometimes people don't take their pills.
And medicines don't work very well if they're not taken. Somehow it's another adage of how things go. So we've covered the basics about how transmission is blocked. It's through behavioral changes, it'd be either condom use or abstinence, I guess, is 100% effective, but or communities coming together and reducing numbers of partners. But what really has been revolutionary in the last decade and a half is the notion of treatment as prevention. If we identify everyone who's infected, get them on treatment, as you said, they benefit as an individual, but they don't transmit to someone else, and that has a theoretical ability to stop the epidemic. And then for those who are higher risk, uh, you can put them into a PrEP program by injection or pills. How do you how would you tell someone or the public uh, if they ask, can we end the epidemic with these modalities alone? Is that possible? And are we doing that now?
Well, theoretically, it should be possible because we've got both treatment and for people living with HIV, we've got PrEP for people who are not living with HIV. But there are so many different barriers that get in the way of using those effectively. So it's not just about the biomedical interventions, but it's about the behavior, it's about the structural causes of that fuel HIV infections. It's about poverty and discrimination and stigma. It's about racism. It's about barriers to accessing care. And it's about competing priorities for people who may be particularly vulnerable, who are dealing with other issues in their lives, and HIV doesn't necessarily rise to the top. So most models suggest that if you could really ramp up both HIV treatment as well as PrEP, you really need them to be at very extremely high levels in order to, for instance, meet the ending the HIV epidemic goals, which are 75% reduction in new infections by 2025 and a 90% reduction in the US in new infections by 2030. That you really need the combination of the two, which can be synergistic, but it's probably going to take much more than that alone. It really does take programs to support people in accessing treatment and prevention.
So how are we doing in these goals? 75% by 2025 and 90% reduction. Are we going to make it?
Well, we're not on track to make it right now. We're not doing very well. There was only about a 7% decline in new diagnoses in the 5 years from 2017 to 2021. Now, we definitely took a hit with COVID. A lot of programs were shut down temporarily. There was a lot less testing going on, and so probably there was, then an increase in discovery of new infections at later time points. But nationally, we're not doing very well. But what we've seen is that in some cities and in some environments, we're doing quite well. So, for instance, in San Francisco, we have had a decrease since we rolled out PrEP of by two thirds the number of new infections, new diagnoses in San Francisco. That's not to say that we've got all of the answers, because we still have disparities, and there's still a population of people that we've not yet been able to reach with our prevention and treatment tools. And so we're looking for innovative ways to do that.
What do you think is the most effective? Is it all the above or being used at once? Or is there one particular modality? Is it the treatment as prevention seems to be dominating in San Francisco, or PrEP, or is it maybe neighborhood by neighborhood in terms of how it's effective?
Yeah, I think it's really, it's got to be a combination of the two. I think all of the models suggest that just doing one or the other is just not going to be enough, that we really do need to do both things, and that we really need the support mechanisms to get those programs out to people who are exposed to HIV, who may be vulnerable to acquiring HIV, and we're not reaching them with current tools. So we know we're not reaching. We know that the number of people that we're reaching with PrEP is not where we need to be. That it's estimated that only 36% of people who might benefit from HIV have been prescribed. Who might benefit from PrEP have been prescribed PrEP. But that is 94% of white people, whereas it's only 24% of Latino people and 13% of Black African Americans and only 15% of women. So we know that we're not getting to all of the populations that we need to reach with these tools that we have, and that we really need to ramp those up.
Yeah, and that's those two populations you mentioned there are disproportionately affected in the first place. So we really need to find ways to redouble efforts to make that happen. Um, what do you think happens if we end up, by some miracle, having an effective HIV prevention vaccine? Do you think that would be something that would add, and how much do you think it would help us?
I think it would add tremendously, particularly if you could give the vaccine, particularly if people were willing to take the vaccine, which we've seen with COVID is not always the case. But if you could roll out a long-acting vaccine that would supplement both PrEP and treatment, then I think you could really make a dent in the epidemic. That's what at least some of the models suggest, is that could really further drive down new infection rates.
And I think some of the data that I remember from the early 90s, when we were hoping for a vaccine pretty quickly, that the lowest amount of efficacy would be to affect 30% or so of transmissions. Sort of a home run was considered 60%, or anything higher than that could really bend the curves. It seems to me that if we add together the things you said, communities working together, outreach, treatment as prevention to everyone who's identified, and ideally we identify 90% plus of people who are infected, so they benefit and the community benefits. And then we add to that PrEP for the people who are fairly significantly at risk, and then a vaccine. You put that all together, it seems like that together is stronger than the sum of all those parts. Would you agree with that, or is that sort of
Absolutely.
pie in the sky? So you,
No, I think that they really would be synergistic with each other, and it really does. So it really does require these communities coming together. In San Francisco, we have this group called Getting to Zero San Francisco, and we brought together multiple sectors of society. investigators and researchers, but also people who are in community-based organizations and activists and clinical providers and industry, government, universities. They've all come together with the same common goal of trying to get to zero infection, zero deaths, and zero stigma. And I think it really does require that synergistic approach so that we're trying to touch all of these different areas that you've mentioned sort of simultaneously with both prevention, treatment, testing. We're estimating that 97% of San Franciscans who are living with HIV are aware of their HIV infection. That's, again, that's another thing that I think has contributed to our substantial reductions in new infections.
That's remarkable. And I think the ability to translate that outside of the Bay Area, where it just seems like San Francisco and that area has been charged with a major community effort, people coming together. That's not common among other parts of the country. And where I live in the southeastern U.S., it's difficult to come by for a lot of reasons. But um, what do you think? What's your secret sauce? What would you suggest to someone who lives in Alabama trying to organize this? What should we be doing?
I think it really is about what we call collective impact, which is bringing together, what we found was that we had a lot of groups that were doing really great work, but they were doing them in silos and they were doing them individually. And it really came to coming together to then say, for instance, how do we roll out PrEP? And what we realized was we needed to both focus on the providers and getting more providers who were comfortable and able to give out PrEP, as well as educating communities and increasing the demand for PrEP. So both supply and demand. And then also a third group that came together that was looking at how do we measure PrEP uptake. So it's that kind of sort of collective impact approach where you've got all of these multiple groups that are all working towards common goals that I think gets you closer to where you need to get to. And there is a group called Fast Track Cities, and a number of different cities have signed on that are trying to do this same kind of collective impact approach within their cities to bring together multiple groups. And it does take political will and it takes community engagement, as well as getting providers involved in community-based organizations and researchers and universities and government.
Yeah, and our time is almost up, if you can believe that. But when I pull back to the big picture and think about where we started, as you started off in the 80s, and this sort of exploded on the scene, and then we developed tests and then therapies and modalities for PrEP and the understanding of treatment as prevention, and maybe one day a vaccine, it does feel kind of hopeful for the future. And I guess that keeps us all going. But the one caveat that I'd like you to maybe finish up with is this notion that what you do today is good for today, but it's got to be sustained, right? There are new people who are coming of sexual age, if you will, every year. And those folks, even though we may have addressed it with the generation, if you will, before, this effort has got to maintain intensity and sustainability over the next couple of decades. So, what are your thoughts on that, and how can we get that together?
Yeah, I think that's really critical. So even when I talked about PrEP and PrEP uptake, that's really just who's gotten a prescription. That doesn't mean that people stay on PrEP, and a lot of people stop their PrEP use, sometimes for good reason because there's been a change in their sexual practices, but sometimes for a variety of other reasons that make them vulnerable to becoming HIV infected. And as you said, we've got new generations that are coming up that also need to be educated and have services provided to them. There's also, as you mentioned, in the South, we've got more than half of the new infections in the country are in the South. And that's also where a lot of the Medicaid expansion hasn't occurred. And so people have less access to resources. But there are other kinds of resources that are being put into the mix. And so I do think that it's going to require innovation. It's going to require consistency. We can't take our foot off the gas. We need to continue pushing forward with prevention, and we need to be sure that we're engaging new generations as they come up, as well as not forgetting about older individuals, because sometimes we seem to think that older individuals aren't still at risk of HIV, and they are. We still see infections in people who are in their older age categories. And so it means that we have to stay aware, we've got to innovate, we've got to engage, and we've got to make access easier for people nationally.
And to wrap up, your final thoughts. Are you hopeful for the future? Do you think we're going to continue to improve over the next 10 years or so?
I am hopeful. I do think that there's a lot more on the horizon as well. There are injections that may occur even less frequently for PrEP. There are monoclonal antibodies that may become available for prevention. There are monthly pills that are in testing right now that could be used for PrEP that would make it much easier to take a pill once a month rather than once a day. There are all kinds of innovations happening in the field of prevention that I think will really help us. And there's innovations in the treatment arena. And so the more tools we have available to us, with the recognition that it's not just the biomedical tools, but it's all of the structures around those that we need to support in order to get to our prevention goals. But I am hopeful that we can really turn things around. There's no reason not to be, and we've got to just work as hard as we can to get there.
And maybe one day a vaccine. That would be great.
There's a lot of exciting work going on in HIV vaccines right now. So that's also something that's very hopeful for the future.
Right. And I'll refer folks to Dr. Kalp's interview that on the podcast where he goes into great depth on what those new approaches would be, ranging from mRNA technologies to really the essence of creating an injection that will stimulate the production of broadly neutralizing antibodies in vivo. And that would be kind of a beginning of a home run, I think. Susan, thank you so much for joining us today. Very informative, hopeful, but at the same time, kind of sobering when we think about how much work there is to do, not just in the Bay Area, but throughout the United States and around the world for that matter. So thank you for joining us and enlightening us on this approach.
Thank you so much for having me.
Thank you for listening to this episode of Going Antiviral. Catch up on earlier episodes wherever you listen to podcasts, and check out the video versions of this episode and others on the IAS-USA YouTube channel. You can find these links in the show notes, or simply go to YouTube and search for IAS-USA, and there they are. Be sure to subscribe, rate, and review Going Antiviral on Apple Podcasts. This podcast is for informational and educational purposes only and is not intended to serve as medical advice. Opinions expressed in this podcast do not necessarily reflect the opinions of the IAS-USA or its affiliates. If you have a question you'd like answered on the show, you can send it to podcast@iasusa.org to be answered in a future episode.